Good morning, everybody. My name is Daniel Alvarez. I'm one of the radiology residents here at Baylor College of Medicine. I have the honor of presenting today Dr. Quan Nguyen. He's going to be giving a talk today on ER breast imaging real life cases. So just kind of like a few ground rules. If there's any questions that arise during the presentation, feel free to put them in the chat box. We'll be monitoring the chat box and answer the questions at the end of the presentation. Um, so just a brief overview of Dr. Nguyen's accolades. He's currently a faculty position at Baylor College of Medicine. He's associate professor within the Department of Radiology, and he's also a faculty within the Huffington Department of Education, Innovation, and Technology. He has won distinction as University of Texas System Distinguished Teaching Professor, awarded by the University of Texas System Board of Regents in September 2020. He's currently medical director, breast imaging division at the Dan Duncan Comprehensive Cancer Center. Was previously program director for the University of Texas Medical Branch Radiology Residency Program from 2016 to 2020. And he's going to be giving the talk today of ER breast imaging real life cases. So without further ado, I think he's ready to take it away. So that's all you, Dr. Nguyen.
Well, thank you, Dr. Alvarez. Thank you to Dr. Alvarez. He's on a rotation, has to work, so appreciate his time. And I want to thank Dr. Rehani and the Health for the World team for organizing this talk. Usually this talk, the planning goes many months in advance, so thank you for getting this organized. And I want to say hello to the audience throughout the world, all the different parts of the country. It's an honor to get the opportunity to speak to so many people throughout the world in every country. So thank you very much. And what I want to share today is all the real life cases that our institution sees in the emergency room. And so what I have is a collection of cases from our residents, the cases that they see, and I believe this was over a 3-month span, all the cases that come through the emergency room. So when a patient comes to the emergency room, what they're going to be assessed for is an infection, abscess. That's the main reason for coming to the emergency room. Other than that, patients with breast problems usually don't go to the emergency room. They will go into clinic. So for our residents with abscess reporting, this is the wording that they have for their reports. So the number that we use is 2.5 centimeters. If there's an abscess that's over 2.5 centimeters, what we do at our institution is we refer the patient to interventional radiology for drainage. When it's smaller than 2.5 centimeters, we ask that the patient come to a breast clinic to have it evaluated by a breast imager. So in the USA, the law is it's called EMTALA, and that law is that the emergency room has to treat anyone that comes in and has to stabilize them. So that's the abscess. And the reason for emergency room versus, say, the clinic is that patients often without insurance will come in through the emergency room, and there are economic and financial implications to this. Most of the time you're going to the ER, you don't have insurance, and outpatient, you do. And it's also a quality issue in having these acute issues managed. So the clinical exam is an important part of the exam. And in the emergency room, often you're not getting a breast imager. And also the ultrasound technologist is not a breast ultrasound technologist specialist. So when they come through the emergency room, we always ask them afterwards to come to our clinic. So with the clinical exam, really what you're trying to distinguish is breast cancer versus breast abscess. And here I have images of clinical exams of cancer versus infection. So usually with breast cancer, what you'll see is a lump in the breast. The other inflammatory breast cancer, what you can additionally see is peau d'orange, so the skin looks like an orange peel. And for infection, so down with breast abscess, what you see is reddened skin, and sometimes the pus can be dripping out as well. And there's what else, another finding on clinical exam for breast cancer Paget's disease, as you can see there, is abnormal skin findings around the nipple. And inflammatory breast cancer, you can also see redness and edema of the breast. And there's some overlap with infection and breast cancer. So this is important why we have the patients come to clinic, even though they start in the emergency room, because most of the doctors that don't specialize in breast cancer, this is not something they see on the regular. So for good care, we want them to come to Smith Clinic so that they are not, breast cancer is not missed. Patients with breast cancer do come to the ER and they get misdiagnosed as an abscess. And so it's very important that they get diagnosed correctly because the treatments are different. So not all breast masses are breast cancer. You can't always tell through a clinical exam. I mean, the ultrasound is going to help distinguish. But here are some examples of masses on the clinical exam. A fibroadenoma is a benign breast mass, and on clinical exam, they're mobile. And there's an image of a breast cancer, invasive ductal carcinoma, two different examples. The one on the top right, looks red and doesn't have to be painful. Usually it's the infections that are painful, but sometimes when they get very large, breast cancers can also become painful. And then, on the bottom left is another example of a lump in the breast. You can see it's not oval and smooth. And that's, similar to like an ultrasound. It's not an oval mass, it's an irregular mass. And bottom right is another example of how breast cancer can present, where the cancer is behind the nipple and pulls it back. Not all nipple retraction is bad. If someone's nipple has looked like that their whole life, then that's more of how they are, as opposed to a breast cancer pulling the nipple back. So going from clinical exam to imaging. So, if you Google breast abscess on ultrasound, these are the examples you get. And here, what, I'm circling here in red, and I circle in blue. Basically, what I'm trying to show is that the ones I'm circling in red, those do look like an abscess, where they look like fluid collections with flowing debris. But like the one in blue, I mean, that one also looks like cancer. So there could be this overlap in the imaging. And so that's why it's important to go to a breast specialist, because they're more experts at evaluating this on clinical exam, and also evaluate with real-time ultrasound scanning. So breast cancer versus breast abscess. So this on the left is on ultrasound how breast cancer would look, and on the right is a good representation of how an abscess looks. So what you're seeing here with the breast cancer invasive ductal carcinoma, how it's different with the breast abscess here. So what you see with the cancer is an irregular mass. And if you look to like the surrounding breast tissue, it's not swollen. So it's just an irregular mass there with the cancer. And with the abscess on the right, I guess these are good textbook pictures, is that this abscess has the swelling, and then there's a fluid collection with debris inside of it, and it's leading out to the skin. And when you have breast cancer or abscess, you can also have lymphadenopathy. And so this could be tricky because the lymphadenopathy, it doesn't have to be metastatic lymphadenopathy. It could be reactive lymphadenopathy. And there is overlap between the two. Uh, so it's when you have enlarged lymph nodes, thickened cortex, those are abnormal lymph nodes. So reporting, I put this in the first slide of how our residents put the reports together for abscess. And the focus a lot of time is the size of the abscess. And so the reason the patients that they go to the emergency room, they come to the clinic is, again, the resident is not a breast specialist, and abscesses, it's not always an abscess and then cancers get missed. So in addition to ultrasound tech, also not specializing in breast. And the residents now are dealing with a static image as opposed to real-time scanning. So when they go to the clinic, they get examined by the breast imaging specialist. And the breast imaging specialist is evaluating with ultrasound real-time scanning, not static images. And again, the importance of, even after you're getting evaluated in the emergency room is going to the clinic so that breast cancer is not missed. Again, abscesses, it's not always that, and then cancer could get missed. And I've seen that many times. So it is a big danger of going to the emergency room without dedicated breast imaging ultrasound technologists and radiologists. So with our residents, they'll put in their report in the ER. Formal diagnostic imaging workup is recommended with the mammogram and an ultrasound on the side of the symptom at the clinic. So further exams to order, again, if something's over 2.5 centimeters, we want it drained right away. So, in the ER, we don't have the breast imaging specialist there, but interventional radiology is available. So we refer to interventional radiology to do the drainage. When it's less than 2.5 centimeters, we get them into clinic as soon as possible for evaluation, and then we can drain those in clinic. Now, if it's not an abscess, depending on the age, if they're under 30, what we do is we do ultrasound. If they're over 30, then they'll get the mammogram and the breast ultrasound to evaluate the area of concern. So when I said I'll show real life cases over a 3-month span, it looks like it's actually a 6-month time span of cases that our residents have seen and that I collected so I can share in this presentation. So first case here, 27-year-old female, and the clinical history is concern for left breast abscess. So that's the usual clinical history when someone comes to clinic. Really, this slide, it's important to digest it. The clinical history, the age of the patient, what they come in for, that's helpful. And so this patient is 27 years old. Usually with these cases, you're thinking abscess and make sure you don't miss breast cancer. So when I think 27-year-old, have I seen breast cancer in 27-year-old? I have, but really it's not that common. Usually, even people with breast cancer, they're young. Usually it's, in their 30s, but it can happen, but not common. So this most likely is not going to be breast cancer. And, abscess is definitely a possibility. So, just looking at the age of the patient and thinking about what's likely to be is important before you delve into images. And also after, you delve into the case, you also want to make sure, like, does this patient have any other prior imaging? Because that could be helpful. So this is the image of the ultrasound of the left breast. And so when I look at this, I showed you guys pictures early in this presentation of abscesses and cancers. This does not look like an abscess or breast cancer. Again, abscess, it's like, swelling breast tissue, and then there's a fluid collection. And then with cancer, it's an irregular mass. This here, it's an oval mass. And so it doesn't look like cancer or abscess. So we see oval masses, and I'm showing two slides because they're two two different areas in the breast. So left breast, 9 o'clock, 3 centimeters from nipple. There's this mass here that's 1.3 centimeters, and there's some color flow. And then here's another location, the left breast at 1 o'clock, 7 centimeters from the nipple. It's very similar in appearance. So what I'm thinking with multiple similar oval masses, again, I'm thinking benign, and what is that usually? It's usually a fibroadenoma. So that's what I would report is an oval mass. And usually in these cases with oval masses, you would follow up in 6 months to demonstrate stability. I believe with this case, let's see if there's prior imaging because, like I said, with cases, you want to look at prior images. So in this case, in the ER, this is the report is, so the first thing is to address the clinical issue. There's no abscess, no drainable fluid collection. And again, when things get done in the ER, patients are still referred to clinic so they can see a dedicated, breast specialist. And so given the ultrasound is operator dependent, a repeat ultrasound is recommended, so in clinic. And then it looks like the mass at 9 o'clock, the similar oval mass, was imaged before. And so it was stable. And so all these masses, again, like I said, are most likely fibroadenomas and will be followed up. So it's that 6-month follow-up to make sure everything's stable. So as I said, whenever someone comes in, look at the history, but you also see if they had anything previously. And so the patient did have prior breast ultrasound 1 month previously in the clinic, and that that mass was seen before and recommended for follow-up. So the patient came in the clinic, did not have an abscess, did not have cancer. So not all patients that come to the ER are going to have abscess, and that's what I'm showing today. All the different reasons someone can show up into the emergency room. So this is in clinic previously, seeing these oval masses in clinic previously at 11 o'clock, 6 centimeters from nipple. And then, we had seen this 1 o'clock, 7 centimeters from nipple. Actually here it's showing a biopsy clip, meaning it's previously been biopsied and pathology proven fibroadenoma. And all the other similar appearing masses are likely also fibroadenomas. So the initial breast ultrasound 7 months prior did note all of these masses, and one was biopsy showing fibroadenoma, and a patient, shows up to the ER later with some concern. Ultimately, it was fine, and just to be safe, we instruct our residents in the reports to say, hey, go to the breast clinic, make sure you get this evaluated to make sure, again, like I said, cancer is often missed in the emergency room because again, in the emergency room, you're seeing everything. So the focus is not just breast. That's case number 1. And here's case number 2. You have a 52-year-old female with left breast painful mass. So when again, when you start a case, you want to look at the history. It's helpful to think it through with the history you're provided, the age of the patient, and what they're coming in for. And then also, you want to look in your electronic medical records. Do they have prior mammograms and ultrasounds to kind of help you on your current exam? And so 52-year-old, again, an age that you could have breast cancer, there's a mass, so cancer is a possibility, but usually with pain, you're thinking, usually infection, not cancer, has pain. Now again, if a breast cancer has been there for a very, very long time and is now very big and breaking out through the skin, it could be painful. But in most cases, when you're seeing pain, you're thinking more infection. Well, let's look at images though and see what we have. So in this case, here's the left breast ultrasound in the ER. And what's interesting here again is, again, it's not an abscess. Not all patients that come through the ER, as you can see now with the first 2 cases, are breast abscess. And in this case too, it's actually not breast cancer. When you look at these ultrasound images taken by the ultrasound technologist, again, you never want to miss cancer. And this is not an irregular mass that looks like breast cancer. And it also does not look like the abscess I've shown you, like a fluid collection. In this case, what we're seeing here, it looks like you're seeing a superficial vein. And so I don't know if you've heard of this entity before, but it's called uh, superficial vein thrombosis. And the term that is used is Mondor's disease. And so it will show up on ultrasound as this dilated vein, and it could be painful. And so this is a case of superficial vein thrombosis, Mondor's disease. So this type of thrombosis, it's not life-threatening at all. It's a benign finding. We categorize as BI-RADS 2, and the management for it is kind of cold compresses and just treatment, symptomatic treatment like Tylenol for pain. And so that's what this is when I look at the images. And here are additional images of that area. So this was the previous images was in sagittal view, and this is in the transverse view. So you have that dilated vein. So here's in the emergency room, our resident is how it's reported is they report what they think, which is they think Mondor's disease, superficial thrombophlebitis. But again, we always, we let them know for two reasons. Again, we want the patient to get good care in the clinic. The quality is higher there, and in addition, also, legal liability. You don't want that in the ER. That's really, this is not your area of expertise. So, referring it back to the clinic for evaluation, protects the residents legally also. And so, residents with all the reports, they have this at the end is formal diagnostic imaging workup is recommended, bilateral mammogram, and so a left breast ultrasound to the side of the, symptom in the clinic. So that's case number 2. So the first 2 cases already, we have not seen abscess, and it hasn't been cancer either. So, but we will by the end of this presentation, where you see that there's cancer that comes through that doesn't get diagnosed as cancer in the ER, and we're for sure in this presentation, going over abscesses, we'll get to some of those. So in this case, this is case number 3, 37-year-old female. History is important. She had a recent right lumpectomy, and now she's come in with right breast and chills. And again, I said it's important to look at the prior imaging. We know she had prior imaging because she had right breast cancer and a lumpectomy. So to get to that point, she had to have had prior breast imaging. And the history here is a right lumpectomy 11 days ago. So right from the history, what am I thinking? So I'm not thinking breast cancer. She just had, a surgery, a right lumpectomy 11 days ago. So usually after a lumpectomy, what can happen is you can have, a fluid collection like a seroma, or you can have a hematoma. So those are things that can happen. She also has this right breast pain and chills though, so you are kind of worried about an infection like abscess. So those are, what I'm thinking before I even see the images with the history is, what a postoperative collection, or it could be an abscess as well. So, well, the clinical exam is important. See how the breast looks. Is there redness and pain, fluctuants to suggest abscess and infection? And if you don't have that, but it's just kind of a lump in the breast, it could be just a post-op collection like a hematoma or seroma. So here we go to the ultrasound imaging. So what you have here is it's a fluid collection in the breast. So are we thinking abscess by looking at these images? So if you've seen, say if you saw this, this image somewhere else in the body, what would you think? Even say the ovaries. So oftentimes when you see a finding like this is really what a hematoma would look like. You see kind of inside that's not like flowing debris, but it's like reticulations within this fluid collection that this looks like a hematoma when you look at it. So it doesn't look like a dirty fluid collection with debris. So, with the history of a lumpectomy recently, 11 days ago, this is most likely a postoperative fluid collection, a hematoma, which is a common fluid collection after a lumpectomy. So that was transverse views, and here's sagittal views of the fluid collection. And so this is the report, not by resident, but the faculty report. And so the faculty report is fluid collection in the right breast compatible with a postoperative seroma. If there is a clinical concern for infection, aspiration by interventional radiology may be considered. And then there's a recommendation for a follow-up ultrasound in 4 to 6 weeks to make sure the area is getting smaller or is gone. And so that was the report by the faculty. So, in this case, there's a faculty report because if they come within the normal hours, 9 a.m. to 5 p.m., the clinic is open and the resident will consult with the faculty. And the faculty here is not outright calling it BI-RADS2 benign. And the reason for that is, again, the faculty did not get to, real-time ultrascan the patient, and to be safe, they want to have the patient, at some point come to the clinic to be assessed by a breast imaging technologist and real-time scanning by the faculty to outright call it benign. So it's likely that this patient had come to the clinic that with real-time scan, the faculty could have outright called this BI-RADS2 benign, given the clinical history and real-time scanning. So just like I said, this patient had imaging previously. And so looking at the imaging previously, this was the mammogram 7 months ago. You see dense breast tissue. I'm not seeing, they have a lumpectomy, so we do know they had cancer, but I'm not obviously seeing the cancer here in this mammogram. And 7 months ago, this an ultrasound was done. And so, the mammogram is not that, evident, this mass, but this patient felt a lump in their breast when they were in clinic. So in addition to mammogram, they get an ultrasound. And an ultrasound, you do see the breast cancer. And this breast cancer, actually, it does look like a fibroadenoma. Oftentimes, these masses that are oval, that they look like fibroadenomas, they could be triple negative breast cancer. They're very aggressive cancers that can't start off oval and circumscribed and rapidly grow. So this ultimately was a cancer, we know, previously to the lumpectomy. So actually, in addition to the mass you see in the breasts, on the right, there's images of an abnormal lymph node. So when you have a mass and abnormal lymph nodes, that abnormal lymph node could be secondary to a breast cancer, so metastatic lymphadenopathy. So a combination of the mass with some lymphadenopathy, instead of just thinking benign mass, your mind is starting to think also, could this be cancer with metastatic lymphadenopathy? All right, so the first 3 cases, no abscess yet. And so here's case number 4. Again, they're always coming in for evaluation for abscess. So in this case, 59-year-old female, evaluation for breast abscess. This patient, similar to the patient previously, had a history of a lumpectomy. In this case, it wasn't just 11 days ago, it was 4 months ago. And it was for ductal carcinoma in situ. So let's see what we have on ultrasound. On ultrasound here, we do see, now it's, again, a fluid collection that's close to the skin, and you could see, kind of it tracking towards the skin. So in this case, this could be an abscess here. Looks like a fluid collection. And it looks like there's some skin thickening. And so, this on the superficial surface there, looks like the skin is thicker than usual. So this could definitely be an abscess. Let's see how the report is. So more images of what looks to be an abscess. Let's see what the report says here. So the resident report says abscess. And again, they want to be safe and says malignancy, is not excluded yet, and referring the patient to the clinic for further evaluation. And this was reported as 4.6 centimeters in size. Oftentimes we would have interventional radiology drain it if it is, over 2.5 centimeters, but in this case, the resident refers the patient to come to the clinic. So, the patient's prior imagery. So she did have an ultrasound 3 weeks ago, and we see here, the fluid collection. It looks actually bigger than it was currently. So it looks like maybe it got smaller. It looked like with the tract skin, maybe some of the pus had gotten out and through the breast. And so that breast ultrasound 3 weeks ago by the resident was loculated fluid collection, suggestive of abscess. So it looks like the patient never got to the clinic yet, and they were going to the ER, over and over again. And so just the history, again, I said this patient had, previously had been diagnosed with ductal carcinoma in situ and had a lumpectomy. And it looks like after the lumpectomy, down the road there, it was, 4 months later. So usually the postoperative fluid collections, will happen earlier on and won't have redness and pain. And so this fluid collection was an abscess. And in this case, here's the original cancer. Ductal carcinoma in situ will be calcifications on mammogram. And so that was the initial cancer that I want to show you here on the mammogram. That's measuring 3.2 centimeters of calcifications. Case number 5, 27-year-old female, new breast mass. And so I am not necessarily thinking cancer. Again, a 27-year-old can have cancer, but the ultrasound imaging will be obvious. So patients that are very, very young, and they do have breast cancer, like the mass is like it's a irregular, big mass. So let's see what the ultrasound looks like. So we're not really seeing this big irregular mass here. So like I said, it's this 27-year-old does not have breast cancer. What she does have here is, so this is a fluid collection that's again tracking towards the skin. In this case, you can see the skin is not as thick, but this still does look like an abscess, an infection. So 5 weeks ago, she did have an ultrasound ER also. And so it's similar that she had this fluid collection previously. I think the more current ultrasound, I'm going to look back here, you can see it tracking towards the skin. So it's a little bit more obvious when this one's an abscess. I think that the ultrasound here 5 weeks ago is a little bit more tricky. Like you don't necessarily for sure see that like this fluid is tracking towards the skin where the pus is brushing out and breaking out through the skin. Like this could overlap, like I said, look like an irregular mass too. And so clinical history, clinical exam, the whole picture is important in coming through your diagnosis. So the impression, the recommendation, again, like we said in the ER, we tell our residents to, we say BI-RAD 0, incomplete, go to clinic to get evaluated by dedicated breast specialists. So the report here is ill-defined fluid collection with surrounding edema, consistent with abscess. And so in addition to interventional radiology, someone else that can take care of these infections in the ER are surgery consultations. And so not even breast surgeons, but surgeons can also do an incision and drainage. So they can either see a surgeon or they can have interventional radiology drain the abscess and send it for testing so that antibiotics can be tailored towards the infection. So in addition, the recommendation in the report was to follow up with the ultrasound in 2 months to make sure that everything is gone. And so with the faculty here, how they report it is abscess, phlegmonous changes, there's the measurements there. And so it can be referred to surgery. And then with the follow-up ultrasound in 2 months to make sure everything's resolved. And what's, if they see surgery and they take care of it, there's really nothing to follow up. So in that case, in these reports too, if you are someone that's able to assess it on real time and put the whole clinical picture together, you could call it a BI-RADS 2. And surgical consultation, if they do an incision drainage, there's not going to be anything left to follow. So now if they don't have an incision drainage and they just get interventional radiology to take out some abscess, then yes, it'd be good to follow up in 2 months to make sure that there's nothing there anymore. Case number 6 here. We have a 55-year-old, and again, the history is very similar all the time. It's evaluating for an abscess. So 55-year-old, they can have an abscess, they can have cancer, all is on the table. So like I said, in addition to history, did they have any prior recent mammograms or breast ultrasounds that can give us more information and guide us. So the last mammogram was negative. So, and on the ultrasound current day, we see here, when I'm looking at this, the ultra, what we get in the ER are static images. So I'm not able to scan this on real time. And so what I'm seeing here is if you look at the image here, it's labeled like nipple. And so that's helpful. And then there's, well, it says right breast 8 o'clock. I mean, if it's just the nipple, there may not be nothing going on at all. It could just be, the nipple and then like nipple shadowing behind it. If this is 8 o'clock, like around the nipple, like this can just be, shadowing from the nipple and nothing going on at all. So, when you look at this and the last mammogram was negative, it's possible that this is just shadowing from the nipple. We just have static images, and the nipple area is a hard area. And when you're not, an ultrasound technologist that always ultrasounds the breast, you could be fooled into, saying there's a mass. But again, if I'm in the ER, I'm saying, go to the clinic and get this evaluated because this may just be nipple shadowing, no mass at all. But again, you can't exclude a mass like that. The way these static images look, that could look like just an irregular mass also. And so I suspect this could just be the nipple shadowing. So let's see what the report would say. Ultrasound of static images. And so this is a faculty report. Again, like it was, done during the hours of 9 a.m. to 5 p.m. So what happens is a resident calls the clinic and has the faculty look at those static images. And so the faculty reports that static images demonstrates no definitive sonographic abnormality. Images by technologists in the subaerial 8 o'clock region likely represent nipple shadowing. So evaluation is limited without real-time scanning and refer the patient to come to clinic so that we can look on ultrasound with real-time scanning to make sure that there's no mass there, because we definitely don't want to miss an irregular mass in breast cancer. And so we suspect that it's just nipple shadowing, but we want them to come in to make, once we look at it ourselves, not just some static images, to conclusively rule that out. So that happens also when patients come to the ER. Like I said, the quality is not as good. And, you want to go to a breast specialist to get that evaluated to clear. Case number 7, 51-year-old, and now again, roll out abscess. Any recent mammograms or breast ultrasounds? So last mammogram years ago, there's the mammogram, not really seeing anything. It's a negative mammogram. And on the ultrasound, the ER here, what we see here is, what do we see here? Is again, we want to rule out cancer. Is this an irregular mass, breast cancer? I mean, that's not completely excluded. I'm not thinking breast cancer. This does look like it's like associated here, close to the skin and a little bit of skin thickening here. There's some color flow around it. It could be an infection with some, inflammation in the area. I'm not so certain at this point. So this is not something I would just clear out right as, either like, I'm not saying this could still be cancer. This could be an abscess as well, given its location by the skin. Could be, the beginnings of a small abscess. But at the same time, this is not like a clear fluid collection. So this is something that would for sure need, follow up. Here's some more images. And images here, this looks benign. Looks like either it's a simple cyst or it's by the nipple there. It says like only 3 centimeters from nipple. So it could be a duct also. But yeah, these images taken by the tech on static, they look benign. It's just these other pictures here, not definitive what's going on here in the left breast at 6 o'clock, 2 centimeters from nipple. So here's the report by the resident. They are saying an irregular 0.6 centimeter hypoechoic lesion may represent a small abscess and go to the clinic for further evaluation. And so let's see here. So that was the end of that case. Let's see. So ultimately, what is this possibly? We'd have to evaluate in clinic. What do I think? I mean, there's a lot of color flow around it, but it's around the nipple. This doesn't have to be cancer. It's not a slam dunk cancer. And this is not, necessarily an abscess either. This would be, again, if we see the patient and, there's signs of infection, then we'd want to, get them some antibiotics and do a short interval follow-up. And if it didn't look like an infection and we just have this finding and we see this, if we do it on real-time scanning and it's doesn't look like an irregular mass, then we could follow it up in 6 months and just make sure that this finding is something that stays stable and is benign. So that's ultimately, if this patient, we does end up in the clinic, that's how I would deal with this case. Case number 8, a 61-year-old female. So tender, so painful, indurated breast mass. So it's painful. The word indurated, that's that's a word sometimes that is used to talk about inflammatory breast cancer. So let's just see how the images look. So right now I'm kind of in my differential is still kind of breast cancer as well as abscess. So in this case here, this case now is tricky, right? I'm going to tell you it's tricky because this looks like a superficial, like it could look like a fluid collection here. But I know this case, this ends up being a breast cancer. And so like I said, there could be overlap, right? That abscess, cancer, there could be overlap because this somewhat looks like a fluid collection, but really this is not a fluid collection with debris inside of it. This is actually a complex solid and cystic mass. So there's these solid components, as this being a cancer, not an abscess. So when you go back here, well, let's see, the finding here is a mass at 1 o'clock, 6 centimeters from nipple. So let's see how the resident reports this. So the resident is correct, is not calling this a fluid collection, but as I said, it is tricky. And our resident very strong here, calling it an 8.2 centimeter complex solid and cystic mass at 1 o'clock, 6 centimeters from nipple. So this patient will come to clinic, get that evaluated, and get a biopsy. So again, great job by the resident. Again, you can see this picture has overlap with an abscess, but you can see that, when I showed you pictures of the abscess, it does look different also. Like the abscess, it looked like fluid and debris. This case, you see a mass here with solid components, but definitely a tricky case. So masses that, that have the cystic component, what kind of pathology am I thinking about in terms of, invasive ductal carcinoma subtypes, like things that have cystic components. Oftentimes, the subtype is a papillary carcinoma. So the patient does come to clinic 3 weeks later, and here's the mammogram of this big mass here. And so in this case, also, this mammogram here, what you see is the mass. You don't see any, skin thickening, any kind of edema. And so infection, a lot of, like we saw, you get like swelling in the breast and some skin thickening. So in this case, you just have a mass in the breast. And so this does fit along the lines of breast cancer. And the breast ultrasound 3 weeks later also, here it is. So the mass rapidly, it looks like it grew and it changed a little bit here in appearance. And you also have in the left axilla lymph node with the cortical thickening there. And so here's a faculty report, 9 centimeter irregular mass with enlarged axillary lymph node. And the final path was infiltrating ductal carcinoma. So invasive ductal carcinoma. It doesn't say papillary carcinoma, but that's something you would keep in mind if you saw a mass with cystic components. So there we go. We see a breast cancer now coming through the ER. Like I said, it could be dangerous in the ER because patients, they get misdiagnosed and they don't get the diagnosis of cancer, but abscess. So we're at 9:45 a.m. now, at least where I am in Houston. So I'm going to show cases for 5 more minutes and then open it up for questions. So case number 9 here, we have a 25-year-old with breast pain and nodule. So again, 25, I'm not thinking breast cancer. So let's see what we have here for this breast pain and nodule. So what we have here is, superficial within the skin. This is a sebaceous cyst. Now, on the bottom right of this slide is what a classic sebaceous cyst look like. There's a cyst there, and then there's a tract to the skin. So sebaceous cysts are these superficial kind of, cysts that have a connection to the skin. And so this is a cyst BI-RADS 2, and it's done. Let's see how the report is. So faculty did get to see this, but again, because they only saw static images and not, did real-time scanning themselves, they said sebaceous cyst and, come to clinic. So in this case, 3 or 6 months later, to just evaluate it again and clear it. So I'm sure if they came to clinic, it would get cleared at that time with real-time scanning as a BI-RADS 2. So case number 10 here, 20-year-old female with a fluctuant mass concerning for abscess. So, the history sounds like an abscess here. So let's see the pictures we get. So in this case here, I would consider this an abscess. The age of the patient, it looks like a fluid collection here. And, it is superficial here. And here's the resident report is, superficial collection and abscess. And again, we tell our residents, send them to clinic so we can evaluate them. Case 11, a 50-year-old female. So 3 months, right breast mass with galactorrhea. And she had stopped, the galactorrhea stopped three days ago. There's a concern for mastitis and abscess. So with breastfeeding, you can't have mastitis. And so let's see what the ultrasound shows. So this case here, we know that galactorrhea, so breastfeeding. So this could be kind of normal lactational changes where there's looks like dense tissue and some, looks like some dilated kind of ducts here. With history of if she's breastfeeding, I could definitely think, kind of this being normal. I could look at like, like seeing the surrounding breast tissue doesn't seem swollen. Skin doesn't look thickened. So I'm not necessarily saying anything is going wrong on here at all. I would have this patient, come to get real-time evaluation to see what this is. So let's see how it's reported. It is reported as, complex solid and cystic mass. So similar to a breast cancer we just had recently seen. So let's see if she comes into clinic. So in clinic here, so there is a mass. So that's not kind of breastfeeding changes at all. So the importance, like again, I said, of, just having a static image and only going to the ER, you want them to come to clinic because you see here, they get the mammogram as well. And so we look like we're dealing with the breast cancer again, like that previous complex solid and cystic mass, and here's the ultrasound. So what we're seeing here in this ultrasound looks completely different than the image in the ER, where it just looked like some dense tissue. Here we see an irregular hypoechoic mass that in combination with the mammogram looks like cancer. And so the faculty, calls the mass on the mammogram and the ultrasound, and then gets biopsy, and that comes back as invasive ductal carcinoma. So case number 12, this is the final case, and then I'll open up for questions. 38-year-old female, currently pregnant, and she has palpable area. There's thick purulent discharge that's being reported. So let's see here. So we definitely don't want to miss cancer in a pregnant patient. And so in this case, what I'm seeing here, I'm not seeing cancer. So it's good to end off this case with an abscess. Again, they go to the emergency room to look for abscess. This looks like an abscess. You see a fluid collection and debris within it, and it's tracking out through the skin, and it's consistent with the clinical history of purulent discharge. So this looks like a big abscess that interventional radiology can drain, and also surgery can also do an incision and drainage. So here's the resident report. Irregular, it says it's called an irregular mass here. This says during real-time scanning, there was movement of internal contents favoring abscess. And it says recommend prompt follow-up at the clinic. So here at the clinic here, again, you do see this fluid collection tracking to the skin, the abscess. And in the clinic, it is actually, with all of this, actually not reported as an abscess, but this gets biopsy. So something that overlaps with abscess that we actually see a lot of in clinic is granulomatous mastitis. And this is very common in actually the patient population we take care of. They're more common in the Hispanic population. That's in literature. And there's this, when it's not cancer, it looks like abscess can also be granulose mastitis. And so it is important to biopsy these findings. So often what happens to these patients is they get treated for abscess initially, and then, it keeps on recurring or it doesn't ever resolve. And then if something keeps on happening, they get a biopsy, granulomatous mastitis comes back. And it's important to biopsy and get that diagnosis because the treatment is different. For infections, you get antibiotics, but for granulose mastitis, you also get steroids. So I think we saw a good compilation of 12 cases that came through the ER. I have many more, but we are up in time. We are at 9:50, in Houston, Texas. So I'm going to open it up for questions now. And let's see in the chat box. There are, greetings from Mexico and thank you for the great lecture. Is it possible we see the pointer as description of lesions are made? I'm sorry, I kind of looking at the chat box now, so I wasn't able to kind of use the pointer to show that. But really now I'm opening up to questions. So please feel free to go ahead and I realize that in different parts of the country, like different technologies are used. So if you kind of want to ask questions on how I would deal with cases in different countries in terms of what technologies are available, please go ahead and open it up for questions now. Doesn't look like there's any questions. This here is a picture of Baylor College of Medicine. And so that was kind of my final slide. But since there are no questions, I mean, we do have about 8 minutes, and I think it's always good, the more cases you can see, the better it is. So if there are no questions, well, let me see, chat box one. How can so good question here. How can I differentiate a galactocele from a breast abscess? So in these cases now from the ultrasound image alone, you can have fluid collections for both. So one is, like the clinical exam. So does it, that's going to be a big part of it. So when you do the clinical exam, is there redness? Is there pain? So galactoceles, I would not expect there to be kind of redness and pain like that you would expect with an infection and abscess. So clinical history is going to be a big part of that. And, with abscesses, they're kind of more ill-defined fluid collections. A galactocele would be more of kind of like an oval mass. And then in the galactocele can have like, like two layers, like, you have a layer of the milk and protein and just a layer of fluid. And so, kind of the clinical exam and kind of the appearance on ultrasound, galactocele more like a mass, and then, with fluid, and the abscess more of kind of ill-defined fluid collection. And really to definitively do it, and it's not too hard, is just, put a needle in it and, take some fluid out. And because if pus comes out, then you got, infection. And if it's just kind of milk and, thin liquid, then you've got your galactocele. So and now also with mammogram, if, the patient gets a mammogram, then you can see on the mammogram a fluid level that is characteristic on a mammogram for galactocele. So, well, thank you for that question, and more questions. I'm happy. So here, does elastography have a role to play in making diagnosis in ER? So we don't use elastography. That's additional information. I wouldn't say that elastography is not useful. Again, whatever you have, and depending on what you're used to using, it could be helpful to you. But we don't use it at Baylor College of Medicine. But I think with elastography, what I believe you're using it for is, how elastic is the finding. You're thinking, is this like fluid or is it a solid mass? And so it could be useful, but what's most useful is the characteristics on ultrasound again, Like you can usually by looking at it, does this look like a solid mass or does it look like fluid? You don't necessarily need an elastography for that. But again, if you're accustomed to using it in your elastography and you're good at it, you definitely should use it. It's, everywhere you practice, you could be better at something because you use it all the time and it can help you. So it could have a role, but we don't use it. And we don't feel that we do need it because just the imaging characteristics on ultrasound, we can distinguish solid or fluid. It's the mammogram where like you don't have that information, right? You see a mass on mammogram, and then the ultrasound helps you distinguish, is it solid or is it a cyst or is it fluid? So without elastography. And so I see some thank you messages here. So thank you very much, Saman. And hello from Nepal, great presentation. I wanted to know if abscess mastitis is always BI-RADS 3. So abscess, now, you can do BI-RADS 2 or 3, I would say, with abscess. So if you're confident it's abscess, and I would say you did the scan yourself and you put the whole picture of it's abscess, you can call it BI-RADS 2 and clear it. And then, but if you want to be safe, and now sometimes people do this because they're worried about, oh, what if I miss and I don't want to get sued? And so people do BI-RADS 3 to be safe and say follow up in 2 months. And so you could be safe and do that. But a 2 and 3 are both acceptable. It's just how confident are you? And I'm very confident. Oftentimes I'll call it BI-RADS 2. So there's not a rule that you have to call it a 2 or a 3, but both are on the table. And so it just depends on how confident you are. And again, something that motivates people is, oh, I don't want to be sued. What if I miss? Like I said, if I have an 18-year-old, it's an abscess. Like I have not seen a cancer in an 18-year-old. So it just depends on, the whole clinical picture. All right, Mark, thanks. And, hope to see you and everybody in here accomplishing your dreams. Can we get a video? This is, from what I know, this presentation that I just delivered is going to be available, to the public online in 48 hours. I'm really happy, though. I did share a good compilation of cases today. So we saw it all, the cancers, the abscesses, post lumpectomy, fluid collections, benign masses. We saw the whole spectrum. So I'm happy I was able to share that with the world so that, again, you might not always see this in your practice. So being able to share this all with you, so helps to increase kind of what kind of like artificial intelligence. The more you see, the smarter you become, and helps you when you see cases. So thank you so much, everyone. We are now at 9:58 and just 2 minutes left. So it looks like everyone got engaged, started asking questions. So we are out of time. So I won't share any more cases, but happy to have been able to share these cases with you. It's a great honor to be able to present to everyone throughout kind of the world and all the different countries. So thank you very much for your time. And so the world is smaller than we think it is. So I believe that maybe our paths may cross, like some of us at some point in the future. So if that does, that would be great and awesome. Have a great day, everyone. Thank you very much.